All right, today we're going to tackle a really important topic: how you actually treat bipolar depression. Now, this is one of the most challenging parts of the disorder, for sure, but there's a surprisingly structured roadmap that clinicians follow to manage it. So let's dive in and see what that strategy looks like.
So what's the big challenge we're dealing with here? Well, it really boils down to this number, 3. For folks with bipolar disorder, the depressive episodes last, on average, 3 times longer than any manic or hypomanic phase. This isn't just a brief dip. For a lot of people, it's the mainstay of their illness.
And because they stick around for so long, these depressive periods end up creating the biggest burden on a person's life. We're talking about their work, their relationships, just their general well-being. It's way more impactful than the periods of mania. Which, of course, brings us to the big question, right? How in the world do you treat a depression that is this persistent, this complex, and carries such a high risk? Well, let's break down the game plan. Okay, first things first, we need to really understand why bipolar depression is such a unique challenge. The stakes are really high, and believe it or not, the wrong approach can actually make things a whole lot worse. This is why getting the diagnosis right is just absolutely critical. You see, treating bipolar depression with the standard antidepressants you'd use for unipolar depression, that's kind of like flooring the gas pedal in a car without brakes. You can literally push someone straight into a manic episode, or even worse, cause their moods to start cycling faster and faster. And the risk here is no joke. Somewhere between 25 and 60% of people with bipolar disorder will attempt suicide at least once in their lifetime. That is a higher rate than any other affective disorder out there, and it's exactly why the treatment strategy has to be so careful and so deliberate.
Okay, so let's get into the treatment itself. The absolute foundation, the starting point for any plan for bipolar depression, begins with a class of medications we call mood stabilizers.
And here's the key thing to get, right? The main goal isn't just to lift the depression, it's to create overall stability. A mood stabilizer is designed to prevent the person from swinging way up into mania, while at the same time bringing them up from the low of depression. It is all about finding and holding that stable middle ground. So in this foundational toolkit, you've got 3 main players, and each one kind of has its own personality. You've got lithium, which is the old classic, super effective, and it has this unique anti-suicide property, but it has a really narrow therapeutic window, so it needs very careful monitoring. Then there's lamotrigine. It's fantastic for depression because it kind of puts the brakes on glutamate, which is one of the brain's main go signals. The catch? You have to increase the dose very, very slowly, so it's not a quick fix. And finally, you have valproic acid, which boosts GABA, the brain's main stop signal, though it's usually more of a second choice for depression. And this is where things get really interesting. A major study found that for a lot of patients, just adding an antidepressant on top of their mood stabilizer didn't actually help any more than the stabilizer by itself. This just hammers home why the whole approach is so different. That mood stabilizer is the real star of the show. So what if a mood stabilizer by itself just isn't cutting it? Well, the next step often brings in a totally different class of medications, the atypical antipsychotics. Now, these drugs have a pretty interesting backstory. They were first developed to handle the psychosis you sometimes see in manic episodes, but researchers eventually discovered they're also incredibly effective for bipolar depression. They basically work on key brain chemicals like dopamine and serotonin to help regulate mood from both ends of the spectrum. And with these medications, it is always a balancing act between how well they work and their potential side effects. Quetiapine is a really common first pick because it's effective and most people tolerate it well. Olanzapine is a powerhouse. It works great, but it comes with a serious risk of weight gain. And then you have Lurasidone, which is a fantastic newer option that avoids those metabolic issues, but it can cause this intense inner restlessness called akathisia. It's all about finding what works for that specific person. But listen, a really comprehensive treatment plan isn't just about pills. Let's talk about the other powerful tools in the toolbox, especially for cases where medications need a little backup. For the most severe treatment-resistant cases, you have brain stimulation therapies. Now, ECT gets a bad rap from the movies, but it is one of the most effective treatments in all of psychiatry. I mean, just look at that response rate, almost 74% in one study. That's huge. Then you have TMS, which is a less invasive option that uses magnetic pulses and is also showing some really great results. And this part is just so important. Think of it this way. Medication helps stabilize the brain's chemistry, but psychotherapy gives you the skills to manage the illness for the long haul. Things like CBT help you rewire negative thought patterns. Social rhythm therapy zeroes in on keeping daily routines, sleep, diet, socializing, rock solid. These therapies are absolutely essential for preventing relapse. So, how do clinicians actually put all of these different pieces together? Well, they build a strategic, personalized plan that follows very clear, methodical steps. And this right here is the whole philosophy. It's not about just randomly throwing medications at the problem and seeing what sticks. It's about a patient, evidence-based process. It's about giving each treatment enough time at the right dose to really see if it's working before you even think about moving on to the next step. Okay, so this is it. This is the roadmap we've been talking about. Clinicians will start with what's called a first-line therapy, one proven medication like Quetiapine or lithium. If that doesn't get the job done, they move to the second line. That might mean switching to another first-line drug or trying a combination. And for those really tough, treatment-resistant cases, there's a third line, which brings in the heavy hitters like ECT and ketamine. You see, it's a clear, logical progression. And that kind of leaves us with one final thought to chew on. As we get smarter and smarter about this illness, maybe the real future isn't just about finding the next miracle drug. Maybe it's about using all this structured knowledge to empower patients, to help them become active co-creators in building their own unique, personalized path to lasting stability.